morning, everyone, and good afternoon, and good evening to some of you as well. Welcome to our webinar. I am Tien Jiang. I am a dentist and faculty at the Harvard School of Dental Medicine, as well as a co-investigator at the Center for Integration of Primary Care and Oral Health, otherwise known as CIPCOH. So we are gathered here today by a great group of panelists. So thank you all. I'll introduce you in just a second. But this is the second of a four-part webinar series and organized by CIPCOH. And we will be focusing every time on different ways where integrated healthcare can help close gaps in healthcare delivery. And so today's talk will be on mental health and COVID-19. Just a few housekeeping items first. We plan to speak for about 45 minutes with our panelists, and then we'll close out with 15 minutes of Q&A to answer questions from our audience members today. And speaking of our audience members, we are very happy to welcome researchers, clinicians, educators, students, all across the board and all across the country, US, and as well as the world. We have some people, last time I checked, from Greece, from the Netherlands, from South Africa, the Philippines. So welcome everyone. And first, let me just talk a little bit about CIPCOH. So CIPCOH is the Center for Integration of Primary Care and Oral Health, like I mentioned. We are a cooperative agreement with the Department of Health and Human Services, Health Resources and Services Administration. It is a multidisciplinary and multi-institutional agreement and collaboration between the Harvard School of Dental Medicine, the Harvard Medical School, the Massachusetts College of Pharmacy and Health Sciences University, as well as the University of Massachusetts Medical School. We also have a great number of individual collaborators, and I'll mention them at the end. We are part of 6 academic centers, and we joined by one of them today with Dr. Klusaritz, focused on primary care training enhancement. We are a national resource for systems level research with an emphasis, as I mentioned, on training enhancement to train primary care providers to do 3 things. One is to deliver high quality, cost-effective, patient-centered care that promotes oral health. 2, to address oral health disparities. And 3, to meet the unique needs of all communities. So I'd like to introduce our panelists. First is Dr. Heather Klusaritz. She is the Director of Community Health Services at the Penn Medicine Center for Health Equity Advancement. She's also the Director of Community Engagement for the Center for Public Health Initiative at UPenn, and the Associate Director of the Center for Community and Population Health in the Department of Family Medicine, and faculty in the Masters of Public Health program at the Perelman School of Medicine at UPenn. She is also on the board of Western Clinicians Network and Alameda County Dental Society. She is a member of National Association of Community Health Centers Clinical Practice Committee and Health Policy. She also is the board member of the Dental Board of California for 11 years. And Dr. Lay at several dental universities. Thank you, Dr. Lay, for being here today. Next, we have Dr. Philip Wang. He is the Chair and Chief of Psychiatry at the Cambridge Health Alliance here in Massachusetts, and faculty at Harvard Medical School, as well as the previous Deputy Director of the National Institute of Mental Health. and the Deputy Medical Director and Director of Research for the American Psychiatric Association. Thank you, Dr. Wang, for being here today. And it found that the prevalence of depression symptoms in the US during the COVID-19 pandemic was more than blank higher than before the pandemic. So pre-pandemic versus during the pandemic. And I'll post this right here for you all. Thank you so much for your participation. And here are the results. We have a very bright group of attendees today. So that's correct. It's threefold, so 300% increase since the pandemic. So if you just did a quick Google search of mental health and COVID-19, if you did it right now, you're going to see all these headlines here and much more in the literature as well. So for example, here, act now to get ahead of the mental health crisis. Again, the collateral damage of our community if we don't focus on our nation's mental health. The New England Journal of Medicine in September came out with this article, A Pandemic Within a Pandemic, talking about intimate partner violence and the spike during COVID-19. And here, what I referenced in that poll question before, the depression increases more than threefold in the wake of a pandemic. And this was a BU study written in the Journal of the American Medical Association. And being a dentist myself, this one definitely caught my eye. Also a couple months ago in the New York Times, a dentist sees more cracked teeth. What's going on? And this is, again, when dental offices were starting to open up more. Dentists, including myself, saw a lot more fractured teeth. So this kind of gives us the context of today's talk. And so I wanted to jump right in there with our panelists. And I wanted to start with Dr. Wang. Could you give me a little bit of context here on mass traumatic events and mental health? Oh, I think you're still on mute, Dr. Wang.
Okay, can you hear me now?
Yes.
Great, thanks, Tien. And just thanks for inviting me to participate in this really wonderful event. By way of context, things weren't good before the COVID pandemic. I think probably this group is aware, mental disorders are unique in that they're very common. 1 in 5, Americans suffer from a mental illness in any given year. They're also unique in that they're largely disorders that start when you're young. Over half of people who are who will get a mental disorder have the onset before age 14. 3/4 have the onset before age 24. The situation in terms of mental health services wasn't good before the pandemic either. It follows the rule of what we used to call the rule of halves when I was at NIMH. Of the 60 million Americans that have a mental disorder in any given year, less than half get anything in terms of mental health care. Of those that get anything, less than half get care that you would consider to be minimally adequate, maybe likely to get them better. And then of those that get minimally adequate care, less than half actually recover in terms of an improvement in their symptoms and functioning. The other thing just to note, care at least in the US is also marked by disparities. African Americans and Hispanics are less than half as likely as white Americans to get mental health care, and Asian Americans are only about 1/3 as likely as white Americans to receive mental health care. This is almost certainly going to, it almost certainly has gotten worse as your poll question indicates. We don't have hard data yet, but I had the privilege of participating in a study of the impact of another disaster, Katrina. And it's instructive in terms of what we are currently living through. We found that people in the Gulf Coast and New Orleans, again, about 1/5 had pre-existing mental disorders. What was worrisome was about half of those failed to get follow-up treatments after Katrina because of the devastation. And so that led to a whole bunch of exacerbations because people weren't getting good care. Their major reason for not getting good care were adverse social conditions, things we call social determinants of health, making it clear that we need to be screening for those and meeting our patients' social needs. What was more worrisome was that 1/3 of the respondents in New Orleans and many in the Gulf Coast who had never had a mental disorder experienced the new de novo onset of one. And what, again, was concerning among these folks is only about 20% of them sought out any treatment, despite having very severe symptoms and impairment in functioning. So making it clear that we're going to probably have to do outreach, develop new forms of ways of reaching people. And I think that's at the heart of what this group is thinking.
Thank you so much for that context, Dr. Wang. And along the same lines of context, Dr. Klusaritz, could you tell us a little bit more about also the integration or lack of integration of behavioral health and primary care and kind of the history in that? Because I know a lot of your work is focused on that merging of two things.
Thank you. And I would also like to, as Dr. Wang did, thank you for inviting me to be here with all of you today. So when we talk about the integration of behavioral health and primary care, we have a really robust literature base that integrated models are good for patients and good for providers. There's increased provider satisfaction, there's increased patient satisfaction, and we see positive outcomes for patients as well. But despite this robust literature base that's been accumulating over the last couple of decades, what we know is there are a number of barriers to establishing integrated models of care. And what we know is that these are barriers that can be overcome, that there are many folks around the country here in the United States and actually around the globe that have been successful in overcoming these barriers, but they're important, and we need to make sure that we're helping primary care sites around the country really overcome those barriers. I'm going to talk a little bit about what we know. So first and foremost, there are some knowledge gaps that we need to overcome. There is limited awareness of how the scope of care that behavioral health providers can provide in a primary care setting, and certainly a need to increase the understanding of the interplay between behavioral health conditions and the chronic conditions that primary care providers have been caring for all along. So certainly behavioral health providers that are in primary care settings are there to help with mental health conditions, substance use disorder conditions, but what they also can do is play a role in helping with management of chronic disease. And so we know that increasing knowledge of the kind of scope of practice of those behavioral health providers in primary care is critical. The other thing that we know is that behavioral health integration requires practice transformation, and it requires behavior change on both the part of primary care providers and behavioral health providers. You can't just train both sides of the interprofessional team and put them together and expect that they're going to work well as a team, right? So what we know is that we have to be willing to make changes in how we do warm handoffs between providers. We need to be open to changes in length of visits. For an example, sometimes behavioral health providers are very accustomed to having an hour with a client, and in a primary care setting, that might look very different. We need to overcome some barriers of practice transformation activities around patient record sharings and electronic health records, and what some people believe is a overly restrictive interpretation of privacy laws for patients. So there are some practice transformation activities that need to be addressed to make sure that we can do integrated care models well. I'll mention, I know we have a lot of international folks on the call today. Here in the United States, we have some unique billing characteristics, reimbursement models that create barriers to integrated models of care. Those are going to look differently across the globe, but here in the United States, those are a barrier for us. A fourth barrier is provider shortages. So if you look across the nation, we know that we have shortages in both primary care providers, but also in behavioral health providers. And we're working, and HRSA is supporting the scale up of the behavioral health workforce. And then finally, and perhaps the most difficult to overcome, is stigma. We here in the United States and in many countries around the globe still hold profound stigma for individuals with mental health or substance use disorder conditions. And overcoming that stigma is a very challenging barrier. Intuitively, it makes sense that we would get care from the neck up in the same place that we would get care from the neck down. But that stigma is something that we're working hard to overcome.
Thank you for that, Dr. Klusaritz. And I'm going to lean into the stigma part a little bit here. Dr. Lay, I know that in 2017, you were the first dental clinic to combine with a wellness center and to try to hopefully address that stigma there. And also the part of integration of behavioral health and oral health with primary care, there's a long history there as well. And so if you could describe, I mean, you're in the Asian community where being Vietnamese American, I can relate to that too. I know it's not unique to Asians or Asian Americans, but there's certainly a stigma around mental health services. So was it an interaction with a patient or several patients that helps you to say, hey, this is, we have to integrate, I'm going to do this and create this integration?
Hi, good morning, good afternoon, or good evening. Again, thank you. Just like the previous panelists, thank you very much for the opportunity to share with all of you, our story and our innovative approach. Yes, to answer your question, it's kind of a very complex process how we started. But really it started from our own interactions with our patients. And actually it came from my staff, who came to me and said, Dr. Lay, we have this patient who's really depressed. When he was checking out, he was telling us that he was thinking about suicide. And then we had, a teenager basically that came and, she was in foster home. And she just said to us, she was going to go home and kill herself. And then we had an elderly patient who kept coming in for denture adjustments. And usually when we do dentures, patients probably come back maybe 3-4 times for adjustment. This particular, elderly woman came back in like 20 times. And like every day. And we didn't, so after we talked to her, finally, she ended up in my chair because my staff couldn't really handle her anymore because why is she coming in every day, Well, so it turned out that she was very lonely. She was in her 80s and she was living by herself and she was lonely. And after I talked to her, and then she said to me that, well, I think that my bank teller is stealing money from me. So would you mind checking my checkbook for me? She was just lonely. She was depressed. She just wanted somebody to talk to. And then we also had, an HIV patient. Actually, he came in and basically thanked all of us, for all the work that we had done for him. And then he told us at the very end of his visit that he just came back from his physician's office. He was told that he was HIV positive. So he advised to all of us that we should get ourselves tested. So we basically said to him, we're not worried about it, just go home and take care of yourself and all that. Well, the next morning we read in the newspaper, he had shot himself. So all of these things, just were kind of happening at the same time. So I had, so basically the staff came and said, Dr. Lei, what are we going to do with these patients? So I had an opportunity to meet with my CMO and my behavioral health manager at the time. And interestingly, Asian Health has about 25% geriatric patients, which is really high compared to the average geriatric patients in other community health centers. I believe the average is anywhere from like 8 to 11 maybe, but we have 25%. And as we were talking about developing a geriatric curriculum for our geriatric patients, for our providers to use, I brought up the idea, of screening for depression for our geriatric patients. And I was just so surprised that my CMO and my behavioral health manager said, yes, let's do that. We haven't even thought about that, but let's just do that. And this was about 5 years ago when the conversation started. So then we just wanted to focus on geriatric, program at the time. This year we started spreading, to other age groups. And that was really a request coming from our specialty mental health specialists. So that's sort of, and then personally, I go to my, my husband is military retiree, US Air Force. So I go to the, the Air Force Base Hospital. And at that time, anytime I go in, they actually have me fill out the mental health questionnaire. So I was thinking to myself, you know what? If they can do that, why can't we? Okay. And if we think about it, the general appointments are so much longer, than medical appointments. Most of us we do develop a very, intimate relationship with our patients because the appointments are so long. So like I said, I basically just jumped in there and just kind of, do that. And it sort of worked out, and we're just really happy to do that. And about 3 years ago, when we opened our general clinic, we were able to hire a licensed clinical social worker to work for us, right in the general clinic. Now, our general clinic is not co-located. None of our dental clinic sites are co-located with medical. So when we started, people thought, well, how are you going to be able to do all the warm handoff and warm connection and all that? But we overcame that, because we're close enough, that we were able to overcome that. So we're just really lucky that we now have our own licensed clinical social worker who is embedded in the general clinic. She's just like basically right next to us. So our patients are able to get the, the care on the same day, or be scheduled, for treatment.
Thank you for that. That story is sad to hear, those stories that you heard from your patients, but at the same time, it was the impetus for you making this great leap and integrating in your space. And it's really a great model that I wanted to showcase today. Dr. Wang, we've had conversations before about this and why integration of oral health and behavioral health makes sense. And when you brought up those numbers, those stark numbers about 14 years old, I think is what you said, and 25, that's really young. So why in your lens does it make sense for behavioral health and oral health to integrate?
Yeah, it makes a lot of sense for the reasons that my co-panelists are describing. because of stigma, you know, the goals of integrated care models are to give people access where they are going to go, which may be less stigmatizing. And you know, the models, the team, the collaborative measurement-based care models that Dr. Klusaritz was referring to, you know, there are 80 plus clinical trials that have shown that they're effective, not just for improving clinical outcomes. I've had the privilege of participating, being the PI of one before I left Harvard. And we did this in Fortune 500 companies, and we showed that workers not only improved health outcomes, but actually improved their work outcomes too. They were able to work and be less impaired. And others have shown that these also are one of the few evidence-based ways, these integrated care models, of actually mitigating disparities, because they're uniquely effective and cost-effective in populations of color. So a whole bunch of advantages. I think personally, there are some unique advantages of an integrated oral behavioral health model, in that, as you pointed out, Tien, you see kids for this good, you know, preventive oral care. And for us in mental health, we get there way too late. In other words, disorders have set in, you've lost functioning, you know, within a median age of onset of 14, you can imagine there are all kinds of adverse outcomes that then happen. You don't meet your educational milestones, you don't meet your employment outcomes, you don't meet your social milestones, and that is just terrible. You have a chance to intervene early. Again, if we can develop a collaborative measurement-based care model that works. And my guess is it would look a whole lot like some of the integrated care models that work in primary care.
Thank you for that. And so I'm sure all these models, though, have had to adapt to COVID-19, and access to healthcare providers has totally changed. I know that in dentistry, we had never experienced anything like that, being totally shut down. So what does, and this can be for any of you, what do mental health services look like now? How are people able to access providers? Are there any innovations these days in being able to access a behavioral health specialist?
I'm happy to go first, only because I didn't mute myself. So we had experienced some very dramatic changes over a very short period of time in response to the COVID pandemic. We had been averaging about 2,500, almost 3,000 outpatient visits, which were exclusively in person. And during the week of April 1st, we nearly completely converted to telemedicine, largely televideo, without missing a beat. You know, continuing to have 2,500 or more visits. So people didn't miss their preventive care, which is critical, right? And we also saw advantages. You know, the patients, the no-show rate dropped, actually. Interesting. We also made dramatic changes in terms of asking our clinicians to risk stratify, because as was mentioned, there's a bit of a culture change. You know, when clinicians are used to seeing patients for a full hour, there's a bit of culture change when you hit a pandemic and there's a surge in needs for behavioral health. So we ask clinicians to risk stratify and decrease the frequency of their most stable patients, increase the frequency and take on new, very severe patients. So we actually shrank we had a 1,000-person waiting list for new evals, and it shrank very quickly to about 100 with this risk stratification. So those are two dramatic changes. Maybe I'll and we developed a model, actually, you know about this. We developed a model of outreach, which is not done in mental health care. We don't tend to, we wait for people to come to us, which again is too late. So we developed something called CHA Mindwell, which we're hoping to work with our colleagues in oral health to stand up. And it might be a nice integrated care model. What it is it uses a way to screen, in this case with more than just a PHQ-9. So we can hopefully identify people in oral health and elsewhere who have needs. And if they have very severe symptoms, quickly refer them to a mental health specialist. If they don't have severe symptoms, they just have moderate, say, anxiety or
Hi, Dr. Wang. I think you unfortunately were muted. There you go.
Did it work? Sorry about that. The CHA Mindwell also offers indicated primary prevention, in this case, online CBT for patients who are having significant anxiety symptoms. But that's something that we could, we're again hoping to stand up with our oral health colleagues here at CHA. And in that way, we think we can maybe develop a prototype integrated oral behavioral health program.
And I'd like to build, Dr. Wang, on your comments. I agree that there have been lots of opportunities for us to think outside of the box on how we deliver care, how we do warm handoffs between providers using telehealth. And, we talk about those silver linings of the pandemic, and this is certainly one of them. I want to call our attention to a more specific silver lining that has come, and that is in the space of opioid use disorder. And one of the things that has happened under the pandemic is there has been a relaxing of the federal regulations here in the United States around the requirements for in-person visits for the receipt of medication-assisted treatment, and buprenorphine in particular. And here in the Philadelphia region, as well as across the country, we were able to scale up very quickly because of the relaxing of those regulations, the ability to get the needs of our patients met and to have their care delivered via telehealth without any interruptions in their medication-assisted treatment. And this was just a critical step for the opioid use disorder treatment community and for all of the patients who are receiving care. Really can't underscore enough the importance of this and how it enabled us to not miss a beat in caring for our patients and really preventing overdose deaths. What we were able to do was prevent overdose deaths with the relaxing of those requirements. So we are learning that we have many patients with opioid use disorder who can continue in a telehealth model, and we don't have to continue in the same way where we have these restrictions where we require people to come to in-visit in-person appointments for their medications. And I really hope that that does continue after the pandemic is over.
So, Doctor, I'm really glad to hear that Dr. Wang was talking about his outreach program. In January 2020, our specialty mental health department actually also started, an outreach program. They came to the dental clinic, and we set up a booth in the dental clinic in the lobby, and we had all any patient who was willing to go through that screening. We'll get to do it. We actually set it up so that it was kind of fun. We had like a Wheel of Fortune, so they could actually play that, and then they got a prize for filling out the survey, and then depending on the severity, we would schedule the patient to see the behavioral health specialist or our psychiatrist, so we started that program. Unfortunately, March, COVID sort of took over the whole thing. So during the pandemic, from March until May, we conducted mostly telehealth, as because we were shelter in place. And I must say that, we just completely forgot about telehealth during that time for those 2.5 months. So in June, we opened partially, and then it just dawned on us, hey, we haven't done any of these things. Our medical wasn't doing it, dental wasn't doing it. And when we ran the report, we saw that nobody was doing telehealth, screening for behavioral health. So immediately we started doing that during telehealth. We actually asked the question, had the patient consent, for us to make the referrals, as needed. And then our medical, when I shared it with my medical department, they started doing the telehealth, screening, I believe in August. So when we looked at the data before COVID, the dental depression screening in dental contributed about 8% to the entire agency depression screening. And of course, that's as part of our UDS, measure, so that it's included in our UDS report. Well, during COVID, just in the last few months, dental screening is now at about 15% of the entire agency depression screening. So we are doing our share, of the screening, and we are referring patients. And you mentioned stigma. I think with telehealth, our telehealth mental health and behavioral health visits went up. I think as much as 50%. And the no-show rate went down from 20% to 5%. I think patients feel very comfortable and safe, sitting in their home, during telehealth visits with our mental health specialists. And so I think that the incidence definitely has increased, but in our integration approach, we are doing what we need to do. I received a call from one of the patients who was reluctant to go into counseling last year. Her daughter actually called me on a weekend to let me know that she and her dad were considering calling the authorities to put her mom on a 5150 hold because she was just like not doing well. So immediately I contacted my licensed clinical social worker. The two of us worked with the family, and we were able to refer her to our specialty mental health, immediately, because she was definitely in crisis mode at that time. So things, yes, mental health is on the rise. But I do believe that we healthcare providers are providing much better care to our patients during this time. And yes, I do hope that after pandemic that we'll be able to continue, the same level of care to our patients.
Thank you for that. I mean, I think that the biggest lesson is that we've had to be flexible and adapt, and we really can meet. I know I had a conversation with Dr. Wang. We have to meet the patients where they are. And if they happen to come into the dental office because they have tooth pain, and we can screen them for behavioral health, then that's a way to achieve both concerns and really meet the patients. I know that, being focused on training enhancement as well, we want to be sure, like Dr. Klusaritz was talking about before, that we're training appropriately to make sure that our providers will also be able to adapt and really achieve person-centered care. And at CIPCOH, we did research last year and found that a lot of the graduate dental residency programs, while there is some focus on behavioral health, the strongest is in opioid use disorders in terms of getting training. And perhaps that's because of that epidemic at the time when we did the research. And that's why these program directors are upping the amount of curricular time for these topics. But we hope, and of course our study was prior to the COVID-19, there was a weakness in intimate partner violence screening and a weakness in anxiety disorders and depression screenings. And another layer of it too is we want to make sure that our healthcare providers are doing okay. This has been really challenging for them as well. And so I know, Dr. Lei, you had mentioned that you created a script for your dental providers because it can be difficult. Say you have a positive screening while you're screening in the dental chair. not everyone is comfortable in it, and that might be attributed to the script. I'm going to show it in a second, but walk us through how the script helped and if there was any pushback from your providers. Oh, let me unmute you. There you go.
So when we first started the program, I did not really get resistance from my providers and staff doing this because basically I'm adding more work to their workload, you know. So I didn't really get resistance, but I did get asked by many of my providers and staff, you know, why are you doing this? What is it? You know, what's in it for us, you know, and why are we doing it? So I had to explain to them why, you know, we were doing it. It's really, we are part of the care team, you know, and we know that we have a lot of our patients that come to see us more often. They probably come to see us maybe 3-4 times during the year, but they may not go to see their PCP, you know, but probably once a year, if not even, or maybe even less than that. So that's what our record shows, you know, at Asian Health Services anyway. So when I started, I had my behavioral health specialists come to dental staff meetings to train us on how to interpret the PHQ. You know, at the time we were using the PHQ 7, which we actually created, not even the 9. Okay, everyone was using the 9, but we created our PHQ 7. So I wanted to make sure that our staff understood how to read it, how to interpret it, so that they knew when to make the referrals. And then of course, you know, and we do that training annually. Even with that, some of the providers felt that they were not equipped, you know, to talk to the patients in such a way that the patient would trust them and would, you know, agree and consent, you know, to the treatment. So we developed, you know, my behavioral health manager and I worked on the script that you see right now. And this is just a script card so that our general providers, and of course we have students and residents as well, know, you know, how to approach the patient. Once they're looking, you know, once they receive the PHQ from the patient, they can score them and you know, and if there's a positive survey, they need to talk to the patients about, you know, going into counseling. And as you know, stigma is a big thing in every culture, you know, not just Asian. It's probably more so in Asian, maybe. So anyway, so this script card that you see is just a tool for our providers to use, and we put this in every exam room, so that if they have, you know, a positive survey, they can just grab on it and then just start working. So I have to tell you, like after 3 years, I think our providers are pretty good at, you know, talking with the patients. So this is now more for our students and residents that rotate with us. You know, I had one student that came to me and said, I can't believe you guys are doing this. I've never seen that in dental school. You know, we don't even talk about this, you know. So he was really excited, you know, to learn this, you know, this integrated care approach. Yeah, so basically just like, you know, how you talk to the patient, make themselves feel that you do care about them, and that this is not just a form that you fill out. We actually do look at this, we review it, we are very concerned about your answers, and we do want you to get into care if you can, you know, if you want to. So at Asian Health, you know, I say that we, like I said, you know, we are now at about 50% of all the screenings at our agency, which is huge because we are only a small part, you know, of the entire health center. We, you know, I ran a report very quickly. About 11% of our patients present with a positive, you know, depression screening survey. Out of those patients, no, I'm sorry. Actually, you know, I take that back. It's a little bit more than that, but then we are able to get about close to 90% of those with a positive survey into care. Okay, so I think that we are pretty successful, you know, of talking to our patient and counseling our patients to get into care. Yeah, we had one patient, like I said, last year, she was really upset when our staff gave her the form. She was saying, why do you think I have depression? Why do you think I have problems? Why do I have to fill this out? And just for your information, we actually put the survey in our intake. So it's part of the packet. We have the medical history, dental history, behavioral health, diabetes survey. I mean, everything, consent, everything is one packet, so that they don't feel like we're just singling them out, for just that, okay? So they fill all this out. This patient is Korean. She needed translation. So our interpreter, our Korean dental assistant, interprets, for her. And she just got really upset when it came to that form. She said, are you telling me that I'm depressed? I don't have any mental issue. Why do you want me to fill this out? Well, interestingly, we were able to get into Epic, and we were able to find that she had been seen for counseling at another health center. She left that health center because she was upset. She felt like they were singling her out. She felt like, she didn't have the problem, but they told her she had the problem. So she came to us thinking that we'd just leave her alone. Well, she had no idea that we were actually screening her in dental. So anyway, so it took a while for us to, she filed all sorts of complaints, okay, to my admin, to me, and all that. So we were able to convince her that yes, you do need, to see, counseling and all that. So we talked to her. We spent hours and hours. So we were able to get her in, to care. Well, interestingly, she was also the same patient whose family wanted to put her on the 5150 hold just a few months later. So the care is there. I mean, so we are able to provide access to someone who desperately needed but didn't want to admit that she needed it. So again, I think it's so it's just one of those, and Dr. Klusaritz, you mentioned, behavior, like mental health is a chronic disease, and it is a chronic disease. And unfortunately, not many people will address it as a chronic disease. We talk about diabetes, we talk about cardiovascular, we talk about all other diseases, and we have, chronic care collaborative, but there is no chronic care collaborative in mental health.
Well, we could make the same argument. We're both dentists. Oral disease, seeing that as a chronic disease as well, but that's not today's topic. We could definitely go on for a long time on that. But I know, Dr. Klusaritz, one of the projects you work on is on scalable interprofessional training. So I'd love your input on the training side of things for integration.
Yeah, and before I turn to that, I just want to say, oral health is just one of those areas that has such great promise for integrated models, because you have been working for a long time to make the connection between other chronic diseases and oral health, and the rest of the healthcare system and healthcare professionals are aware of that and have bought into that. And for those our participants in the webinar today, oral health is just ripe for integration of models. Related to the training, I just wanted to spotlight and emphasize Dr. Lay's tools that were developed to help providers get more comfortable doing screening and talking to their patients about their behavioral health needs. In the age of our electronic health records that are prompting us to screen for everything, including social determinants of health, it's really important that we train with an understanding that this isn't a checkbox activity, and that this is a conversation that you're curating with your patients. That's how we establish trust. That's how we make sure that the relationships are there. And that's how we convey to them the importance of the questions that we're asking and the reasons that we're asking the questions. So those types of trainings and tools that we're able to provide for our oral health providers and others are absolutely critical, helping them to learn how to navigate that conversation, helping them to learn how to normalize the screening that they're doing. So providing scripts to them that include phrasing of, you know, I ask these questions of all of my patients because I am concerned about you as a whole person and all of the things that might be impacting your ability to achieve the health outcomes that you want, or in the case of dentistry, the oral health outcomes you want. Other language that you can include in those type of scripts. I wanted to highlight the importance that whether it's mental health or behavioral health screenings or social determinants of health, it's important to train our providers to be in adverse childhood events and to be aware that our patients may actually have had traumatic experiences related to the questions that we're screening. And so in those training materials, making sure that you include language that says, I'm going to ask you a set of questions. If any of these questions make you feel uncomfortable, feel free to not answer, but know that I'm always here for you if you want to talk about that topic, right? And then finally, I wanted to draw our attention specifically to intimate partner violence because it came up earlier. And unfortunately, in healthcare, across primary care, across oral health, across multiple specialties, we have a long history of telling people to ask the wrong question. So the wrong question is not, the question we don't want to ask is, are you safe at home? Especially in the time of COVID, right? Like it just no longer has relevance. So I train trainees to have a conversation about relationships and conflict. And I train them to say something around that sounds a little bit like relationships are tough and all relationships have conflict. Tell me a little bit about what conflict looks like in your relationship. And so that sets the stage for them to then have that conversation with you and for you not to potentially miss any intimate partner violence that they might want to talk to you about that wouldn't necessarily be elicited by the "Are you safe at home?" question. So I love the example of the tool that was provided, and I really encourage our participants that if you're thinking about developing an integrated model, to think about those type of training materials that you can develop, and to reach out to the community of practice that's available via CIPCOH, because these tools exist and you don't have to recreate the wheel. And at the National Center for Integrated Behavioral Health, that's really what we're focused on. How do we develop a set of tools for folks who want to get started in this space, but might not actually know where to get started, and we don't want them to have to reinvent the wheel.
Thank you for that. Those are really great practical tips, and that's exactly why we wanted to invite you all here today. So I do want to address some of the Q&A. That hour went by really quickly, but we have an anonymous attendee here asking, what has been the most prevalent mental health issue since COVID, and how have intervention and treatment been implemented? I know we addressed a little bit of this, but if any of you have comments to that, I would love to hear.
I'm not sure we can say what the single, what condition, has been worsened. I have a feeling it's across kind of the board. Certainly, I mean, just our own experiences as individuals, we know there's a lot of anxiety, and there is depressive symptoms definitely are up as your poll question asked. We have hints that problematic substance use is up. So I think it's kind of across the board.
And for us, what I have seen is just like what Dr. Wang was saying, it's the anxiety, isolation, depression. I see that a lot more than substance abuse, but that's also because we have a very low, I guess, with outpatient population anyway, we have seen a very low substance abuse rate, but we have seen a lot more in the anxiety, isolation, because so that's what we've seen, in our surveys in the last few months.
Yeah, and I would agree with my co-panelists. I think the other thing for us to all be aware of is during this time that we are likely seeing an increase in the symptoms and conditions that we're all talking about, but that they are also increasing in a way that might not yet meet diagnostic criteria, but that prevalence is there across the population. So important to note that while we aren't yet able to capture with data how many more people have received a diagnosis, we certainly know anecdotally, and as Dr. Wang highlighted for all of us in our own lives, that many people are experiencing those suspected symptoms.
Yeah, and I know when I treat patients at the dental center, I've also noticed when I review medical history, there's an increase in addition of anti-anxiety medications, and you know, the impact of that on the oral cavity is definitely of importance for me as a clinician. Speaking of those screening tools, we have a question here from an attendee. Several screening programs were mentioned today. Are there any scoring systems being used with these screening tools? And I know we've discussed a little bit about that, but and I know we could do a whole talk on screening tools, but any insight on the scoring?
Dr. Wang, I feel you are best positioned to perhaps answer this one for us.
Yeah, there are a number of fantastic tools. I mean, probably, you know, the most prevalent is like something like the PHQ-9 or even shorter versions of it. There are other screening tools for other conditions. For anxiety, there's something called the GAD-7 for substance use. There are a whole bunch of screens. So I think maybe, you know, and in terms of the scoring, I think it depends on what the prevalence of these conditions are in the population you're seeing, and the likely severity. You know, so I would choose a threshold for, you know, a score that meets your population's needs. If something's rare, like Dr. Lewis, you know, mentioned, you know, well then, you know, maybe you can, you know, you can adjust your thresholds, but there are many good screens out there for different conditions.
Thank you for that. And we have a question here. We didn't address this too much today. This is from someone in Indonesia. So it says that Indonesia is one of the countries that has been badly affected by the COVID-19 pandemic. This pandemic has greatly affected our daily lives and work, especially in Bali, an island in Indonesia that relies on foreign tourist income. Without a significant income, many Balinese suffer from mental health problems. How do we, as residents on islands who really rely on income from foreign tourists, deal with the COVID pandemic situation? And it, you know, it doesn't have to be specific to the tourism, but you know, this has really impacted, like you were talking about, social determinants of health. What's one way to address when really the economics of this pandemic has really impacted just layers and layers to families and individuals?
I mean, I am not familiar with Indonesia specifically, but I will say one of the things that we know is that not having our basic needs met creates a situation that is ripe for exacerbating mental health. And so I think focusing on making sure that those patients that you serve have their basic needs met. Are there ways to work together across sectors, healthcare sectors, nonprofit sectors, to ensure that people have their basic needs around food met, around housing met, those type of things? It's not necessarily getting at the treating of the mental health condition, but we do know, you know, Maslow's hierarchy of needs start with those most basic needs to help people get some relief around that. And disaster medicine teaches us, disaster response teaches us this as well.
I might just put an underline under that, because, you know, the social determinants of health that we've been talking about, you know, these social conditions, things like, you know, poverty, food, housing insecurity, violence, the experience of violence, trauma. Even before the pandemic, they determine 80% of the variance in all health outcomes, oral health outcomes, behavioral health outcomes, general medical outcomes. And we know they've gotten worse. The social conditions have deteriorated across the globe. And so I just want to emphasize, and even before the pandemic, psychiatric disorders were the leading cause of disability worldwide. They account for 1/3 of all years lived with disability. That has definitely gone up. And so we absolutely need to be screening for and meeting people's social needs. That's a very, very important thing to be doing.
Thank you so much for that. So it's already almost 1 o'clock here. I definitely want to close by saying thank you all for joining us today. It was really a fantastic conversation. And from all of us at CIPCOH too, I do want to recognize my collaborators here and at all the institutions. And we also are planning ahead to our 3rd webinar in the winter, probably around February or March. And this is here, we want to highlight your integration stories. As you can see here with our panelists, it really takes champions on recognizing that this is important, and how do we actually implement this? How do we put it into our curriculum? How do we put it into our clinics? And so as you close out of our webinar today, you will receive a survey. And if you have any stories of yourself or your colleagues, please send them to us, and we would love to highlight what you all are doing in our community. And so with that, I did want to thank you all again, and feel free to reach out to us at CIPCOH, any of the panelists here, and I hope you all have a fantastic day. Thank you.
Thank you.